All right, we can go ahead and get started. Hello to everyone and welcome to the Bridging. Oh, gotta mute people. Okay. Welcome to the Bridging Research and Practice Conference. I'm Kathleen and I'm with Share. This session is mental health peer support in the Department of Veterans Affairs. And today we have Matthew Chinman. Matthew is an investigator at VA Pittsburgh and a senior behavioral scientist at the RAND Corporation. His VA research focuses on peer specialists. He has investigated implementation factors critical to PS development, conducted randomized and quasi-experimental trials assessing PS impact, and prospectively tested implementation strategies supporting PS development. If you have any questions or technical problems during the presentation, please send me a note directly. Again, I'm Kathleen. And if you could all please keep yourselves muted and remain muted unless you've been called upon to speak. At the end, we will have a short time for questions. If you do have questions throughout, feel free to put them in the chat and I'll keep an eye on that as well. All right, Matthew, you could take it away.
Thanks so much, Kathleen. Really appreciate it. It's really great to be here. The only thing I would ask is that in the recording, if I could just be digitally added hair, that's my only request.
We do that, absolutely.
Yes, I think that was in my contract. So I'm going to talk today about peer specialists, particular kind of peer support, and particularly in the Department of Veteran Affairs. I think it's true that it's the Department of Veteran Affairs, the VA, is probably the largest single employer of peer specialists. I know Recovery Innovations is probably right up there too, but I think we are the largest single employer. It's so the VA has invested a lot of money and effort into this, and so I've been in the VA for about 21 years, and you might not know it from my youthful demeanor, so I spent my entire sort of VA career studying the VA's efforts to deploy peer specialists, and so I will talk about that. So I'll go into some brief background on peer specialists, some research literature on peer specialists, and then kind of highlight some VA studies, talk about some conclusions and some future directions. So peer specialists are a key part of recovery in serious mental illness. Peers are folks who are individuals in recovery who train to work in traditional clinical settings. So we view this as a proactive form of peer support. When I was still training, I was at the Connecticut Mental Health Center, and they had, which is in New Haven, Connecticut, and there were a lot of peer support groups there that were great. But what we noticed is that a lot of times people just didn't show up, and it was just really, it felt like we were leaving a lot of good peer support sort of out in the field. Like it was a lot of peer support that was getting unutilized because people were not coming in to participate in the peer support groups. And there had been on some other literature talking about that as well, about how, there were just high dropout rates. People would come for a couple of sessions and then not come back. And so the idea that we thought about is, could there be a way to bring peer support to the people? And that is sort of really, in a way, the embodiment of the peer specialist role. They still draw upon their lived experiences, their empathy, their insights, and serve as role models and do all that stuff. But they do it in the context of more of maybe a one-on-one relationship, sometimes groups, but it's definitely a different role. And it has become a real key part of the VA's move to recovery-oriented care. And some of you who may have been in the earlier session with Ann Klee and Sarah Edmonds, Dan Rogers, you might have heard some of this, but they are VA peer specialists are full-fledged VA employees. They have all the rights and responsibilities thereof. So we currently have, I think, about 1,200 peer specialists working all across nationwide across the VA. So one way to think about the way I think about peer support is really a continuum. So where you have on the one side, over here, this is the most one-directional relationship. It's like classic psychotherapy. You go to an office, you might never learn a single thing about your therapist. They're like a blank screen. I'm a clinical psychologist. This is the way I was taught in grad school. And on the other end of the spectrum here, you have, say, friendship, which should be completely bi-directional. Both parties are giving and taking about equally. And peers are kind of in the middle here. You have peers as providers of conventional services, and then peers providers of peer support. Peers providers of peer support is really the brand that I'm kind of talking about today. And it is somewhat one-directional, but still has all the hallmarks of peer support. So one of an effort that we did back in 2016 was really to try to get a handle on the peer specialist duties and activities. We did a literature review and convened an expert panel, both from VA and outside VA, and kind of boiled down the peer specialist roles and duties to this list. And so there were kind of 5 broad buckets, and starting with, say, symptoms and medications. So peers can have a role in trying to help patients manage their symptoms and medications. Joint goal making. A lot of what peers do are help the folks that they're working with set goals and pursue them, recovery goals. And liaisoning. We've seen that peers can be a really good liaison between a person receiving services and their provider, often giving providers new insights into the patients that they're working with, and really kind of translating back and forth because they really speak both languages. Resources, a key role helping patients connect to resources that the peers may themselves have used, so can speak very directly about. And then we kind of had a catch-all bucket of sort of core peer specialist activities. These should be no surprise to anyone, but sharing their story, encouraging hope, role modeling, encouraging, in this case, veterans to seek treatment, showing empathy, building skills, looking for strengths in people, not just deficits. So this seems to be, I think, a really nice list of peer specialist duties. But I think, as we've seen, they're now, they're being put into a variety of different settings. I think so. This list is even growing more. Who can be a VA peer specialist? Well, the first thing you have to be is a veteran. So that is a requirement for VA peer specialists. You have to be a veteran yourself. If you spent any time with veterans, the veteran-to-veteran bond is very strong. When 2 veterans meet each other for the first time, they're like 40% the way down to friendship already. And so when veterans work with each other, it can be really, really helpful. They also have to have recovery for at least a year, not any hospitalizations or legal issues in the past year. They have to do the job and be able to, talk candidly about their conditions, provide helpful resources, all that. And they're definitely in recovery. They can have symptoms and be taking medications. That's fine. So that's the stuff that really, gives them the experience they need to talk to others with it. So the VA has crafted a nice sort of ladder, for upward mobility for peers. So the and I don't know if folks are familiar with the GS level. That's a government wage level. So every single government employee in the United States has a GS level, and there's 15 levels, and then each level has 10 steps. So it's like this broad ladder of jobs. And so, and then each part of the country has a locality adjustment. So, you're going to, if you have the same job in LA, you're going to be making more than you are in Tennessee. And so there are multiple levels here. So you can actually become a VA peer specialist apprentice at a GS5. That says you don't have certification, but you're supposed to get it within a year. And then all the other levels are requiring some sort of peer certification from an organization that is recognized by a state. And so it starts from the entry level all the way up to a supervisory peer specialist. And these are wage ranges. So, at the highest level, some peers could be making, 70,000 plus if they've been in the VA for a long time. So it's always nice for whatever kind of job you have when you have the opportunity to move up. And so it took a while for the VA to get here, but we do now have these abilities for peers to move up. Really just a brief history of peers in the VA. This all started around 2006. And then in 2008, the first national director of peer support was hired. The big shot in the arm was in 2012, there was an executive order saying that the VA had to hire 800 peer specialists by a certain date, and they met that. And then they kept on hiring. Then in 2014, they created an initiative to put peer specialists on PAC teams, which are primary care teams. I'll talk a little bit about the research study we did on that. And then in the last sort of 10 years or so, there have been additional sort of policies that have been enacted that require different levels of peers to be in different places. So there has to be at least a minimum of 2 per facility, often called VAMCs or VA medical centers. And so, and the last thing that just happened is now there's funding to hire at every medical center in the VA 2 additional peer specialists that are going to focus specifically on substance abuse treatment. So that's the latest thing. So it's been sort of a nice upward trajectory from about the mid 2000s to where we are now. In terms of what peer services look like, this is getting a little old. This is from fiscal year 2018, but there was a big effort to pull like every single stitch of services that peers delivered from that recent year from the Center for Evaluation and Implementation Resources. And so they delivered, in 2018, they delivered 350,000-ish individual services, 80,000 veterans served. And you can see from here a wide range of settings, from general mental health. MICM is the VA version of assertive community treatment, day treatment programs, PTSD, homelessness, sort of you name it. They are really kind of in all different kinds of behavioral health settings, often delivering mostly outpatient, a lot of group work, but individual too. And here I point out that 7% of the veterans that peers worked with have what's called in the VA a suicide flag, which means they have a note in their medical record that they have some history of suicidal ideation or attempts. And so, I know there's been a lot of talk recently about, can peers work with people who are suicidal? And the answer is peers in the VA are already doing that. And so, we could talk about sort of different curricular or different approaches, but peers are definitely working with some of the most sort of the sickest, most impaired people with a lot of problems. So one I thought was interesting was comparing peer specialists both from inside the VA to those outside the VA. And this was Hayes in 2019, did an effort, a part of a thesis, I believe, and did this big nationwide survey. And VA peer specialists do pretty well. They tend to be older, more satisfied with their job overall compared to non-VA peers. More often male, which is consistent with a veteran population, tend to be employed for more hours, tend to be more likely to be certified. Because that's a requirement. Tend to have some secondary trauma stress, but no significant differences in terms of the level of burnout or general stress, and less likely to be considered or to be considering finding another job. So compared to non-VA, VA peers, I think are, fairly satisfied and doing well. What's the underlying psychosocial processes? And this is from Phyllis Solomon. There's a lot of different mechanisms by which we think that peers have their impacts, and starting with social support, just someone there to listen, to provide some basic assistance and positive feedback about a patient's self-worth, experiential knowledge, and that hooks up with kind of guiding people to resources, working with someone who has that, has been down the road before is just super helpful. And social comparison theory, this is the idea that, patients who can see a peer as someone who's doing better, it sort of gives an example of hope of what I can achieve, and gives a sense of optimism and something to strive for. And then also social learning theory, sort of looking at peers as a kind of a credible role model, and having an interaction with peers who are doing well could result in positive behavior change. People learning directly from their peers about what to do and how to do it. So I'm going to talk a little bit about some of the research literature. There's been a lot of studies on peer specialists by this point. Not some of them, not always the most rigorous, because it can be challenging to do this kind of research in a rigorous way with random assignment and everything. But in general, it does seem like that having peer specialists as part of the service mix is beneficial. And when you see all these studies listed here, some of them are VA, some of them are not VA. But in terms of medically, you see improved symptoms. We did a study that showed that. I'll talk a little bit about that. Better engagement with care, fewer inpatient hospital days, better quality of life, the greater satisfaction with life, greater hopefulness, hope being a real big part of what peers can do well in promoting. And then socially, fewer problems and needs and better social functioning. So there's a wide range of outcomes that peer specialists studies have found. Not every single study has found every single outcome, and there's a wide range of rigor that these studies have been able to achieve. But by and large, there does seem to be a nice research base for peer specialists. What we've also noticed is that there are big implementation challenges that peer specialists face. A lot of this comes out of efforts in which the peer specialists were new to a place. And given that we're many years in, we're seeing this less, but it still can be problematic. And especially given the fact that peers are moving into new areas. And every time they seem to move into a new area, like primary care, it sort of reactivates these original implementation challenges. So the biggest one that we saw was role confusion. Not sure, like no one was sure what the peers were supposed to do. The peers weren't sure, their bosses weren't sure, the scope of the work wasn't clear. So that's been an issue. Staff resistance. Back in 2012-ish, I did a whole study where I went to a lot of different VAs, and VAs were just getting up and running with peers at this point. And I just did all these interviews and focus groups about what would you think about having a peer come here? And the reactions from the non-peer staff, clinical staff, was really negative. They saw that peers were going to cause messes that they would then have to clean up. They wouldn't be able to do the work. They would relapse. A lot of that has really not proved to be true, but that's the way they felt at the time. We've really moved, I think, a long way away from that, but there can really be a lot of staff resistance when setting up peer specialists. And that often resulted in things like not having adequate supervision or not being in team meetings that they needed to be in. And also unequal treatment, not having access to a car if the setting was something that, in which the providers were going out into the community. They wouldn't have access to a car. They wouldn't have access to medical records because they felt like they just look up their friends or, just things that were really not based in reality. So we did a lot of work especially in the early days, to try to figure out what improves implementation. One of the biggest things was to include leadership in the crafting of the peer role. It's sort of a classic implementation kind of strategy. When you include stakeholders, then they're more likely to buy in. So we did this whole process where we would have the existing team help craft the peer specialist role, making sure that who was going to provide training was definitely thought about ahead of time, and then making sure to set up a good supervision system for the peer specialists, even before they arrive. So in this slide we have, and I can make these slides available. I don't know if they're being shared, Kathleen, but we have a toolkit that we put together that has all sorts of stuff about setting up peer specialists. It's tailored for the VA, but it has things in it that would apply to non-VA settings as well. But so this, if you go to that URL, you could download that for free. I could also put it in the chat, I guess, too, right? What? I thought I was going to try to do that. Oh, I guess it's not working. Oh, I see what's happening here. Okay, let's see if I can. I'm having a problem doing it. One more time. There we go. All right. So if you want to go check that out, you're free to. All right. So talk about some select VA studies. Again, the VA is not the only place where peer specialist research has been going on, but it's definitely been a hotbed of research. And so, when you have 1,200 peer specialists in your system, it's a nice environment to do that research. So one of the earlier studies that I did was called, very unoriginally, Peers Enhancing Recovery. VA, you got to have like one of these double entendre acronyms for your studies. So it was a randomized trial of 6 teams, and they were all the VA version of assertive community treatment. And I don't know if folks know about, assertive community treatment. These are treatment teams that have very small caseloads for everyone, and they are very community focused. They're out in the community working with folks. And the patients assigned to these teams tend to be people who have a lot of hospitalizations, get hospitalized a lot. And so the idea is where you give them a lot of wraparound services, and then it keeps them out of the hospital, keeps them sort of more woven back into their community fabric. So these are 6 teams that prior to the study did not have peer specialists. And so we gave 3 of those teams at random 2 peer specialists each, and for about a year. And then the peers basically just did anything that they could to help these patients. They never had sort of primarily administrative responsibility, but they helped out on lots of different patients. We use something called the Simpson transfer model, which is an organizational framework to introduce the peers to these teams. And so that hit on some of the thing I was saying earlier, where we worked with the teams to create the peer role, set it up all in advance, got their buy-in. And so when the peers arrived, we had less sort of confusion about the role. We also gave the teams a lot of training about what peers are and how to supervise them. And we really tried to make the role concrete. So we had about 152 intervention patients compared to 133 controls. And we assessed all the patients on this that were being served by these teams on things like recovery, quality of life, patient activation, symptoms, before and a year after the peers were deployed. We also did some qualitative interviews asking what patients thought about it, what the peers thought about it, what their providers thought about it, the team leaders, sort of about the barriers and facilitators. So the survey results were a little disappointing, but there was an improvement on something called patient activation. And so patient activation is the ability of patients to kind of navigate and effectively be in control of their own patient experience through getting services. And so it's been found to correlate with lots of other outcomes. And so in this study, we were able to show that peers on teams that had peers, those patients had greater patient activation over time. And that really does track, I think, with what we knew to be true, and what we were seeing and hearing is that peers would talk to patients about how to access their services. Don't forget to ask your psychiatrist X, or even going and being in the meeting with their psychiatrist. So they were very active in helping navigate the patient experience, and I think that translated into higher activation. There were no other positive outcomes from this study. The qualitative interviews showed that after some initial growing pains, peers were highly valued, both by the providers and the patients. And that also all the concerns that I mentioned earlier about the peers were completely unrealized, like they just did not happen. And so, and I think it was, some of the providers on these teams really did like a whole 180 around being skeptical to being huge champions. And then there were some stories about how, some of the staff somewhat jokingly, but did not want peers to go on vacation because they were afraid to not have them around in case, some emergency arose. So they became really very much valued. So some of the lessons learned here was that organizational strategies really need to be in place to kind of pave the way for peers to enter into a system. And what we also came to realize is that even systems that have peers, but maybe the rollout was kind of bumpy, you could go back and do a similar organizational process, just kind of restart it. And it might be helpful to kind of take stock if the peer implementation is not going well. A second study we did was called Administering Mission Peer Support, or AMPS. Mission is a practice where you work with veterans who have been homeless in the past and are now kind of transitioning back into housed life. And so there are these things called HUD VASH teams in every city and every VA. And these teams are basically designed to help formerly homeless veterans basically just get back into life. And they're designed to help with kind of everything from, and the HUD part of this is that these folks, patients get a voucher for heavily discounted rent. So, and then with this voucher, they can go to kind of multiple different kinds of places and get housing. And then there's case management on top of that. And so what we did here was we took two HUD VASH teams and then we gave them peer specialists. And then within each team, we assigned veterans to either just usual care, which was just their case manager, or their case manager plus the services of a peer specialist. And then there was a kind of a somewhat structured and unstructured curricula. And structure is a kind of a thing that comes up in the study a lot, I'll talk about. So there was a workbook that comes with the mission approach, and the structured sessions were really just like psychosocial rehabilitation greatest hits. They were just like things like dealing with anger. I mean, it was a wide range, substance abuse stuff.
It's okay.
Concrete things like taking the bus, how to, set up your house, and they were just basically discussion topics that were kind of ready-made for the peers to use. And we gave them leeway basically to kind of use whatever structured session they felt was the most appropriate at any given time. But then there was also unstructured sessions, which were just completely open. And so, if a peer had a plan to talk about, okay, we're going to talk about setting up your apartment and have a whole thing about that. And then the veteran walks in and said, my sister just died. You throw the thing out the window and then it becomes about that. So they had a lot of flexibility. We wanted them to get to all the structured sessions by the end of their time, which was a year, which they mostly did. But they could do it in a lot of different ways, very tailored to each individual patient. We had a kind of a broad inclusion criteria, any substance abuse disorder, any kind of mental illness, and they had to obviously be in HUD VASH. The measures we used were, again, a broad brush of symptoms, housing, life skills, hope, community participation, and then we tracked their VA services as well. 81 controls, 85 intervention. So the basic analysis, kind of what's called the intent to treat, which is basically regardless of what happened, you compare everyone in the control group to everyone in the intervention group and just see what happens. And that didn't show anything. But then we looked at like, okay, who was changing, who was improving? And we used this concept called the reliable change index, which is a formula by which you can sort of see in each individual person who's changing. And there were a bunch of people who in the intervention group who were improving. And so when we then looked at, well, what predicts who is a positive changer? And it's basically, it's a bunch of things, but one of them is assignment to a peer specialist and then being highly engaged with that peer specialist. So what we found was that there was a wide range of those who were assigned to receive peer services in terms of how much they actually utilize those peer services. And so, we couldn't force them, obviously, into coming and meeting with the peers. The peers were very proactive, very engaging. They did their best, but even then, some people just, after they were assigned, just declined. But among those who were engaged, they got, those were some of the folks that were the sort of the best changed folks in terms of something called the basis, which is a broad stroke symptom measure. So there did seem to be an impact on symptoms among those who were making use of the peer services. So if people who are making use of the peer, if people who are hooked up with peers are doing better, well, what predicts people getting hooked up with peers, sort of backing it up a step? And what we found, that was in another study, we found that having a little bit more hope at baseline, having actually more mental health symptoms at baseline, and actually using more services during the study predicted more engagement with the peer specialist. So it seemed like if you have a little bit more hope, a little bit more sort of get up and go, you got lots of symptoms, and you tend to be a service user, because you're using other VA services. These are the folks that were more likely to use peer services as well. And then the qualitative stuff was really interesting too. We specifically asked a lot of questions about structure and sort of like the structured elements versus the unstructured elements. And because this really gets to some basics around like how much are peers told like exactly what to do versus how much they get to sort of make the decisions about what they're going to do on their own. And it really seems like both aspects of the structure continuum were valued. So there were aspects of the structure that it was a regular meeting, that the workbook had some helpful information. That was really helpful. And the unstructured part of it was also viewed to be very helpful. The fact that the intervention was flexible, that it led to all sorts of social opportunities, and it really went to the heart of trying to turn around isolation. So it was, I think both aspects were valued, and it kind of made me think that, sort of a medium level of structure could be the best way to go. And people were really satisfied. Both the case managers who were working alongside the peers were really happy with it, and also the veterans were really happy with it too. Some of the case managers really said that, the veterans, that the peers actually knew the veterans better and had better connections than they did. So the same study, this is like kind of a crazy slide, but the another colleague, Rashut, looked at, what predicts the use of traditional VA services? And he did these gigantic models, one for mental health services and one for substance abuse services. And one of the things amongst a whole host of variables that predicted more traditional service use was actually being randomized to a peer specialist. So these veterans, they not only were working with the peers, but then they were also more likely to make use of traditional VA services. And that also syncs up with a lot of what we know about peers, is that they're good treatment engagers. And, so they do their work directly, but then bring people in to get other services as well. Then I want to talk a little bit about multiple legislative efforts that have spurred the VA peer specialist efforts. So in addition to going back into the early 2000s where there was legislation about hiring them, there have been more recent efforts to place them in different contexts. So there was the Clay Hunt Act, which was getting peers to be focusing on suicide prevention and doing a lot of community outreach. And then there's been an ongoing effort to have peers in primary care. And so the first effort in that was called Peers Impact. And then that presaged the Mission Act, which also put a lot of peers on PACT. So the first one, Peers Impact, was a randomized program evaluation that me and Richard Goldberg from the Baltimore VA led. That started with an executive action by the White House to put peer specialists into 25 VA medical centers, and not just anywhere, but on primary care teams, called PACT. So there were those 25 sites we randomized, and 12 got what we call facilitation, which is basically like implementation coaching. And 13 were then left to just implement these peers and bring them on kind of on their own. And what we basically found was that the implementation assistance, that implementation coaching, was really important. All told, across all sites, they delivered almost 13,000 different encounters to about 5,600 veterans. And these kinds of services had a more kind of positive health flavor to them, not so much mental health, although there was a lot of mental health too. But those sites that got this external facilitation, as it's often called, as coaching, they delivered more services, and they delivered the services sooner than the sites that did not get that implementation coaching. So it was one of the first large-scale efforts to embed peers in primary care. We actually rolled out a peer specialist fidelity tool that we used, and there was better fidelity in the sites that got the implementation coaching. And then this led to the Mission Act, which was an additional 30 sites that got peers who did similar kinds of stuff. So, I think this really showed me that, when you introduce a new thing to an old place, there needs to be implementation support, and peers are no different than that. And so we saw a lot of the barriers that we saw in mental health back 15, 20 years ago, we saw in primary care. Because even though we're all in VA, the primary care folks had no idea about peer specialists until this project, even though maybe down the hall, they were working in mental health this whole time. So, but it was a new bunch of folks, and all the old challenges came up that we had to overcome. And then the Mission Act, Monica Matthews from the Central Arkansas VA did another 30 sites, and they really found that it was also feasible, helpful, and they did a whole bunch of interviews, found that the peers were, again, enhanced VA services. So that effort just ended recently. A couple of other quick hits of other kinds of VA studies. There's Partner MH. This is by Joanne Eliason from the Indianapolis VA. It's really focused on minority veterans, and so Partner MH is a kind of a patient navigation peer approach that really tries to engage veterans of color and really help them given some of the health disparities that they face in care. And then Coffee Socials is a effort out of the Bedford VA in Massachusetts, which is a very open kind of group that is done in a coffee shop in a community, and where peers just invite veterans of all stripes to come and in a very open kind of chat-like way, but on an ongoing basis. And they kind of lead it for a while, the peers do, and then they kind of cede control over to, a veteran. And that's really kind of spreading and really finding a home, and, just giving a forum for veterans to kind of talk to each other about mental health issues, other things, and having that discussion not be at a VA facility, but out in the community. So that's another nice example. So in general, I think across the years of doing research in the VA, it really does seem like those who engage with VA peer specialists get benefit. They're super valued by patients and staff. And that, in thinking of, well, how much structure, I think a medium amount of structure really makes sense, where the peers have some points to hit, some things to get across, but are given a lot of flexibility in how and when to deliver those points. They're really good service connectors and engagers. And I think what we've also seen is, given the implementation challenges, they really need implementation oversight, might be not a great word, but more like a local champion. Because we've seen that when you don't have a champion, then these services tend to kind of get deprioritized and can get cut. But when there are champions, I think peers are given the space to do their good work. So that's another implementation point that we've seen. Future directions, we're looking to get more into suicide prevention. That's obviously a big issue in the VA. And peers, I think, are really poised to be effective in suicide prevention. And this is sort of a model of suicide, and then also sort of what peers are known to be good at. And so, loss of connection, loss of self-worth, and loss of hope are some of the hallmarks of being suicidal. And these are actually things that peers are really good at attacking in terms of community integration, providing empathy, and cultivating hope. So we have an effort in collaboration with Ann Klee, who you might have seen in the earlier session at the West Haven VA, to develop an intervention specifically for peers and suicide prevention. So that's ongoing. And then the last thing is just leave you with a sort of a peer specialist research agenda that I think is sort of a to-do list for peer researchers. I think that we need more theoretical mechanisms and testing theoretical mechanisms to better understand how peers do their work and get the outcomes they get. Continued work on a peer specialist fidelity measure. We know there are some key activities that we like peers to be doing, providing hope, being a role model, sharing their recovery story. And so this measure just sort of gets at that to see what the fidelity to that model is. And then, doing more outcome studies. A lot of, a range of the studies that we've seen over the past many years aren't always the most rigorous. And so we do always need more rigorous outcome studies. And then we want to see, I think, more peers being part of the research team. So we have research peers here at the Pittsburgh VA, which has really been really helpful, and also to better synthesize all the studies that we do have around and get a better handle on the barriers and facilitators that we see to implementation. So I will leave it there. We have, I guess, about 15 minutes for questions.
Looks like Erica has a hand up.
Hi there. Thank you so much for your talk. And I'm just really excited to learn more about your research. So I'm a postdoc at the VA at UCLA, or at Greater Los Angeles, and we've been trying to implement a pilot hearing voices peer support group at our VA. And as a part of that, I mean, some of the pushback that we've gotten from reviewers has been this question of peer service implementation in the VA context and issues of co-optation of, recovery movements or, certain kind of aspects of peer support through more of a top-down implementation structure. And I was wondering if you had any kind of publications on the history of this implementation strategy, and what your thoughts would be, kind of speaking back towards recovery activists on the use of peer services within the VA context, given that hierarchical kind of structure and the lack of a grassroots. I don't know exactly. Yeah, thoughts on that?
So, so I got my start in the VA at GLA. So good to see another GLAer. So I would say that, I think that the framework I was just talking about before around a medium amount of structure could be the answer to that. So yes, the VA is a hierarchical bureaucracy, but I think within that you can allow peers to have, along with other providers. So, I mean, no one would say like a psychologist, no one, like the VA isn't telling the psychologist what techniques to use in individual sessions, right? And so I think similarly, peers have a set of skills that they would be able to apply based on their expertise and their own lived experience, just like any other kind of clinical provider. And so there, again, we did a qualitative study asking about the kind of the structure and how much structure to have. And we definitely netted out at a medium level where there are some key pieces to make sure to deliver, some topics to deliver, but they had a lot of freedom to deliver them as they saw fit. And so to me, that's the best of both worlds, in that there is some structure of a curriculum, that's been worked out, but then they are free to use their own knowledge and experience to make sure that's delivered appropriately. And not to mention, like supervision and, all those other things. So I think there's plenty of examples. And so if you want to email me, I could send you a bunch of papers and we could talk more about that. And so when you said reviewers, you're talking about VA, HSR&D reviewers, or?
No, actually, through the blind peer review process in community mental health journals, we, requested people who had been hearing voices researchers review our first manuscripts. And so, we're getting questions about peer co-production too, and also, the need to make sure that the hearing voices approach has some kind of fidelity tool too that would be used for both peers and for clinicians. And so it's kind of a chicken or the egg situation that we find ourselves in, where we're just starting this pilot. It's not perfect in terms of how to bring in peers and veteran voice hearers into the mix, but we're looking for models and we're looking for, strategies to get this started. And at the same time, we're kind of being confronted by the structure of the VA and how funding works. So it's difficult to get peers hired on research teams, for example, things like that.
Yeah, I can understand. Yeah, we've been there, and so I'm happy to talk with you more about it.
Thanks so much.
Sure.
We have a little bit more time for questions. If anybody has any questions, feel free to raise your virtual hand, or you could even type it in the chat.
There was a good question from Phil Arnold in the chat. Phil, do you want to state your question?
I will. Was kind of on a campaign during 2008, 9, 10, 11, 12 here in the Northern California area about the processing of claims. And to get to the services, particularly through the VA, there seemed to be a challenge getting claims processed. So, the back end of what I've just seen today is just wonderful. There's no doubt about that. But it's just, I don't know if anything has changed since then. And I had recommended that the cheeky thing to do would be to outsource the claims administration to a third party like USAA, State Farm, or somebody else that does predictive claims management, and would be a better process to do that as opposed to adding just more bodies and more training to process the claims. But when you have claims that are sitting out there that are a year old and our veterans are using a curb as a pillow for the night because they can't get through the system to get to the services that were so well aptly described today, there's a barrier. I was just wondering, because I know General Shinseki had moved on by demand from several congressmen and senators, and he was replaced. I just haven't followed up on it. So,
So it's a great question. Unfortunately, that is way above my pay grade. I'm just a lowly researcher, and I have no control or no knowledge about the claims process whatsoever. So I don't doubt anything you just said, but I just really, that's a completely separate thing from like the research that we're doing with peers. But a good point.
well, thank you for that. I'm a veteran. I'm a defense language specialist. I served as a Russian interpreter, monitored Soviet communications out of the Middle East, and for an 18 and 19-year-old, that was harrowing, and some things that I heard. But just service delivery is the key. So I thank you for what you've done. It's just in the detail. Appreciate it genuinely.
Thank you for your service too. So thanks.
Any other?
I didn't mean to end conversation by saying something.
No, that's okay.
No worries.
I guess I'd like to make a statement. It's more of a statement than a question. And that is that it's my understanding, maybe you can correct me if I'm wrong about this, that the VA's kind of been ahead of the curve in terms of incorporating peers, hiring peers, believing that this model is something that's effective and trying to bring it into the system. They were really doing this very early on. Even when Dr. Sharon, our current director of mental health in Los Angeles, used to work for the VA, he was talking about peers way back then. And, so I think it's really useful to see, given that the VA does have a much longer history than most organizations have of working with peers, it's great to see this kind of presentation that you've just done, bringing together a reflection on how effective it's been over the years.
Yeah, I would agree. So the New Freedom Commission, people remember that was like 2002 during the Bush years. And that's where like the first sort of institutional comments about that we should have, representatives, people that had serious mental illnesses as part of the system. And so the idea was really percolating, I think, really since the early 2000s. And then again, took off in 2005 and 2006. I should also point out that the VA is it's not a monolith. The big joke in the VA is if you've seen one VA, you've seen one VA. that the VA, VA's medical centers are really they're the main sort of driver of what services is going to look like. We have these things called VISNs, which are big areas and whatever, and we have central office mandates, but it's really the local medical center. And, you can really see a wide range, I keep mentioning, but the West Haven VA has they're actually a very small VA. They have like 23 peer specialists. The Pittsburgh VA, we have like 5, and we're probably, twice the size of of the West Haven VA. So, and it's because like the leadership at the West Haven, by and large, year after year, has just seen greater value than in Pittsburgh, and so that you do see a lot of variation. But in general, I think it's gone pretty well, VA wide.
I mean, anecdotally, what I hear from peers that I know that work in the VA here in West Los Angeles is that they often seem to have a knack for connecting with people that clinicians have a harder time connecting with. They seem to be able to create trust in different ways, more informal ways perhaps, than clinicians are using in the intervention. So it's a good compliment. Like I've heard of folks in the VA who are like, yeah, could you come in on Saturdays too? Because it's easier to connect with some people. They trust that person more. So and
Yeah,
that seems to be something that's reflected in the research that you're presenting.
I know almost every study that we've done, a provider somewhere says, the peers that you brought in as part of this study have now connected better with some of my patients than I have. It's almost like a universal thing that happens. And I think that veteran bond is powerful, and they just have a different approach, a more open, empathetic, strength-based, caring approach. They really take the time to listen, and so it does seem to be a real effective model.
If I may interrupt one to add to that, because what you say is critically important. The woman that I've been married to for 50 years, her father was one of the original Tuskegee Airmen. And they, 3 days before our wedding, they sequestered me, 3 of them, put a thermometer between my toes and a blowtorch near my bottom of my foot so I wouldn't get cold feet and leave. But that bond was something that I had never, ever seen. And I call it humble swagger because of what they had been through in uniform and disrespected in uniform, where they've been told to take the uniform off, you're not a pilot in Tuskegee, but had done so. That was my second insight into that bond, and that is one of the most powerful brotherhoods that I've seen, the veteran brotherhood, because there's just an unwritten understanding. So kudos to you for recognizing that.
Well, I think we should leave it there. That was really beautiful. Thank you.
Yeah. Thank you all. Thank you so much, Matthew. And thanks everybody who came and listened. If you haven't put your email in the chat, I would encourage you to do so I could send over an evaluation. And the next session is why substance use and mental health peers need a meaningful community, and that begins at 12:30. Feel free to leave this on, or you can come and go as you please. And thank you again, Matthew.
Thanks so much, Matthew. That was really great.
Thanks for having me. Really appreciate
Thanks,
it.
everyone.
And we will, if you are open to distributing your slides, we have gotten some queries. People are interested in sharing.
Yeah,
those.
I'll definitely do that.
Okay.
Should I send them to you or?
You could send them to me or to Linny.
Okay.
From, and then we can get them out to folks that maybe couldn't be here today, but are really interested and want to engage around these issues. So.
All right, will do. Thanks so much. I really appreciate it.
Thank you.